Welcome to part 2 of my Q&A with consultant gynaecologist and endometriosis specialist, Mr. Denis Tsepov. Denis answers your questions on endometriosis. If you haven't seen part 1, you definitely won't want to miss it. In part 2, we cover excision surgery, sick leave after surgery, silent kidney loss, fertility, menopause, and even cancer. It's going to be very educational and eye-opening, and I hope you enjoy it.
So we've touched upon surgery and MDT involvement, more so in terms of bowel endometriosis and when we discussed leg pain. But I want to dig a little deeper on why MDT is essential for endometriosis and the fact that this is lacking in many of the endo centers across the globe. As we've discussed, endometriosis is a complex condition and affects multiple organs, each case differing in the specialisms required. Now, I must reference my own experience here as a patient of yours, because when I was searching for an endometriosis specialist and I saw that you have more or less every kind of specialist under the sun in your team, I thought to myself, bloody hell, he's got an endometriosis army. And I was honestly blown away to finally come across an endo specialist with multidisciplinary capabilities, from colorectal specialists to urologists to hepatobiliary specialists to cardiothoracic. After our initial consultation, I met with your co-surgeons before my surgery, and I learned about each organ involvement separately, and that was imperative to my own education as a patient. And when I watched my surgery video back, which is incredible to have, I was shocked at how thorough and gentle and meticulous the surgery was, because I'd exposed myself to what endometriosis surgery looks like. And you'll see a lot of surgeons just poking and prodding a woman's insides as if they're not a human being. So I would love for you to talk about your MDT that you've built, why it's important and how you went about recruiting your team. So, yeah, take it away.
Yeah. Thanks, Lena. Yeah, I think endometriosis considered to be gynecological disease, right? So endometriosis, you go to gynecologist, but it's actually much more complex than this, because endometriosis, as we know, is a multi-organ disease, a systemic disease, and it can affect just about any organ, any internal organ, including bowel, bladder, ureters, lungs, diaphragm, nerves, other structures, skin, and basically the main problem, I think, if where the endometriosis surgery fails, is when it's abandoned due to unexpected complexity. Okay, because if you're alone and you're a gynecologist, yes, you can be like a super gynecologist and train to do everything yourself, but that's rare. I'm trained to do bowel resections. I am trained to do ureteric implants, but I'm not doing those because I think that to protect the patient and protect the surgeon, you need a proper specialist to undertake a very specific, very narrow part of surgery, but it should be done with the highest proficiency and highest responsibility for what we're doing as a team. Okay, that's why I really support the idea that a multi-organ involvement must be dealt with multidisciplinary team, and that doesn't diminish me as a gynecological surgeon, because I know my skills and I know my partner's skills as well. But I think it's the right thing to do for the patient, for the success of surgery, and and as far as endometriosis surgery is concerned, I mean, for the completeness of excision where it is appropriate, because it's the last thing you want to do a big surgery and then abandon it halfway through just because, I didn't know there is a bowel resection needed, so I can do it, but I mean, do I need to? That kind of stuff, we really want to avoid this kind of stuff, because if surgery is abandoned, means another surgery is needed. Every other surgery for endometriosis patient is more risky and less successful. So we try and do one surgery if we can, I know we have sometimes reservations for fertility, etc., but one surgery to be as radical as allowed by the patient circumstances, and we really have zero tolerance to residual endo as part of our sort of philosophy in our center because of this multidisciplinary team. And the team is something you can select. They not only have to be like great surgeons, and in my center's cases, like robotic surgeons, right? They all robotically trained guys, but also they need to understand endometriosis, because if you take a random colorectal surgeon, oh, there's this colorectal guy is around, let me ask him to help me. And I've seen that happening, and that's a very wrong thing to do. Because if you have this sort of concept, yes, I'll have a colorectal surgeon if I need it, whoever is available, that's a very wrong thing to do. Because colorectal surgeon needs to meet the patient, needs to understand the patient, and we have like MDT discussion where we discuss all the MRI scans and everything and CT scans as a team, and we formulate the strategy of surgery, and then we discuss it with the patient. Right? If we cut corners like this, then inevitably we'll have either a surgical which is too radical, because colorectal resections for endometriosis have to be like economical. They're not cancer. We don't need to take huge part of the bowel, and we just need to remove what's really needed with the very narrow margins and avoid accessing the area which is full of nerves, because that can impair the function. We need to do a very, very economical, very specific type of bowel resection, which is very different from resection used in cancer surgery. Same with urology. Urology surgeons, we all know that we don't need to remove, for example, if we have a bladder infiltration, right? We don't need to remove the whole bladder. Like for cancer, sometimes it's the only way to go. For endometriosis, we just need to identify where the nodule starts and ends, remove that very part of the nodule, and then do a very economical resection, knowing this is not cancerous disease. And then it's very, and you don't really have a colorectal surgeon doing exclusively endometriosis. It doesn't happen. All of them are cancer surgeons, right? Or they deal with inflammatory bowel disease. But if you identify a good person and a good surgeon, you can start introducing endometriosis concept to them, and most of them are good enough to understand it like quickly, straight away, and then they become a single mind with you, being endometriosis colorectal, endometriosis urologist, endometriosis hepatobiliary or thoracic surgeon. Endometriosis is a specific disease which needs a very different mindset.
Yes, it's I think people will presume if there's a surgeon who specializes in cancer, then endometriosis should be really easy for them. But as you're saying, it's actually a
The
completely
opposite is
different
true.
approach. Opposite is true. Wow. And for you, I'm just curious personally with building your team, because like I say, it's not like you've just got even just one colorectal specialist. I believe you have about 3 colorectal specialists, and you've built this team even to target cardiothoracic endometriosis, which is very rare globally. So just curious as to how you built, did that happen gradually, your team?
Yes, so it doesn't come as granted. And obviously, and I had this experience in building the team within the NHS. And that wasn't very easy sometimes, because people are very, there is a limited commitment someone can allow in a extremely overloaded and busy cancer services, to allow his time, and that's like a proper commitment. At least once a week we wanted to do something with the bowel, or something with the blood or the ureters, and that's all day commitment to non-cancer services, because and that's with NHS being overloaded and sort of not very efficient. That was very difficult to convince someone to compromise their cancer waiting list to do endometriosis, and that's the it's not only about that, it's just the problem of the health service itself, because cancer gets priority, endometriosis is pushed backwards for understandable reasons, but it shouldn't be like this. It should be, priority should be given to all people who are suffering. In private sector, it's a little bit easier to do, because if you see a great surgeon and if you see he's practicing in the same private hospital group, it's easier for me to invite someone to be part of the service that we organize, because there is allocation of time and effort for that. But still, you have to be very selective and really know the person very well before you can invite someone to do endometriosis surgery with you. And that's invitation based, because you really identify a good surgeon, you identify a good person, you identify person who has huge empathy to women, and really that's how the service is done. So it's all based on a very, very huge passion for women's health. After all, this is the main thing.
Yes, I mean, from firsthand experience, I very much got that impression from your team that there was no question around my symptoms, no invalidation of pain, or downplaying the seriousness of endometriosis, which rarely happens generally in the healthcare system. It's quite misogynistic, if I can say so.
No, I'm laughing because this is very true, and
Okay.
sometimes, it's shocking. It really is.
Yes, I mean, it's very valuable that you yourself acknowledge that. And therefore, when you're recruiting your wider team, their values have to be in line with yours.
That's
Yeah.
true.
Okay. So I have a few more questions on endometriosis surgery, because obviously it can involve anything and everything. And there are some common questions that came up from women in the comments who are awaiting this Q&A. First one being, is excision surgery the gold standard treatment for endometriosis? And would you describe it as a management tool?
Well, very good question. So excision is a gold standard for sure. And because what else do we have? We have ablation. So ablation is acceptable for a very tiny endo lesion, which you know where it starts and ends. For example, if you have a little spot of endo on the peritoneum, I mean, I still would prefer to excise it, but it's acceptable to ablate it. However, if we're talking about a nodular disease, about deep infiltrating endometriosis, then ablation absolutely is the wrong thing to do, because it will not, to ablate the whole nodule, which is infiltrating into the tissue, then you need to cook the whole area. And if you cook the whole area, you will damage the VIP neighbors in that area, nerves, ureters, blood vessels, etc. So that's a no. If you do a little bit of ablation, then you burn the tip of the nodule, and it doesn't do anything to the disease. It just does not treat it. It doesn't make it better. It only creates more scarring, and it only affects the tip of the iceberg, but the whole iceberg becomes even angrier, because the endometriosis is like a combination of scar tissue and endometriotic glands. And if you burn a little bit on top of it, that doesn't really change how disease is treated.
Yes.
So in short, excision is the gold standard for endometriosis, because even if you have a widespread endometriosis on the peritoneum, on the lining of the pelvis, excising it is not very difficult, and it should be done. And not only we treat the visible disease, but we also attack the microscopical endometriosis, which potentially have the we give rise to recurrent disease.
What micro? So is that because of the cameras used during surgery? You can actually locate microscopic disease.
Not really. No, we
Oh,
assume that microscopical disease, if you have like endometriosis visible, it's visible on the MRI, it's visible with the endoscopic camera. But also, if you have the whole lining of the pelvis looks like it's affected with endometriosis, although it's not a deep infiltrating disease, that's microscopical or barely visible disease, which also we need to excise. If it looks anything but normal peritoneum, we need to excise it. And most times it will come back positive with histological examination for endometriosis.
Wow.
And with robotics, the definition of the resolution of cameras are much higher. So we have more and more sort of visibility for endometriosis affected tissues, and it's better to excise them all because, or if you say let's leave this behind because it's not deep infiltrating disease, that's the wrong thing to do because it will become deep infiltrating disease. It will come back. It will continue to cause symptoms. So that's how it works.
Okay. And surgery is a management tool as opposed to your absolute solution. So, of course, a lot of women will go into surgery with the belief because they hear gold standard, it's the best treatment, and they think that's it, job done.
Well, surgery is only one part of the treatment, right? Because we know that endometriosis is a chronic progressive disease, it's systemic disease, and removing endometriosis is an important part. Excision of endometriosis is a very important part of the patient journey. Also, if you remove endometriosis that you can see, the microscopical disease which you haven't seen will continue to progress and become visible at some point, right? So excision of endometriosis and clearing endometriosis as much as we can is really important. However, that the patient journey doesn't stop there because we need to then decide after surgery what we're going to do. Are we going to try for a baby? Are we going to go for IVF? Are we going to not try for a baby for another 2-3 years? And what do we do in this case? Are we remaining on the natural cycle? In this case, the risk of endometriosis recurrence is higher. Or are we using some form of hormonal suppression? In this case, recurrence of endometriosis is lower. And then if we use hormonal suppression, what exactly are we going to use? Are we going to tolerate this treatment? And can we have alternative treatment? And then another layer of care is, what if the pain is still present after excision of endometriosis? What if the pain is neuropathic? What is the pain to do with uterine contractions, which are, exacerbated by adenomyosis? Is there element of dysfunction of the pelvic floor muscles caused by endometriosis? Is there some kind of nerve pain, or is there some kind of psychosexual disturbance because it was all started by endometriosis? So the whole thing is very, very multifactorial. And to say, I'm going to excise your endometriosis, goodbye, thank you very much, is a very wrong thing to do. You have to, once you've taken the patient on board, we feel that from the time when we opened our endo center in 2014, we only lose patients if they go abroad. And because everybody would like to come and say, yeah, I had another baby, I had this, I had that, and my symptoms are getting worse, can you have a look? It's ongoing journey. And the endometriosis center, we really like to see our patients again and again and again, because because everybody will have different circumstances. Somebody wants to have a baby straight away and then another baby afterwards. Somebody wants to give it a pause and use hormonal treatment. Some of them said, no, I cannot really use hormonal treatment because it makes me feel bad with side effects. In this case, we monitor and monitor symptoms, monitor the imaging, and it's just not only surgery. It's a lot of things to consider.
Yes. Yes, it's so refreshing to hear you say that because, yeah, as you will have heard, I'm sure, from many of your patients, that it's not generally like that. You have, even after diagnostic surgery, you're discharged and get on with it, basically.
Yeah, if we have dedication to the service, then you cannot do that. So you really need to, for a surgeon, you don't have to do endometriosis, right?
Yeah.
This is a lifestyle choice in a way. So,
Yes.
and because you have to accept this is very demanding from the surgeon, from the service, and without, again, coming back to the MDT, because our
Mhm.
surgical MDT is like colorectal, thoracic, etc.,
Yeah.
urology. But our second round of MDT is psychosexual counseling, clinical psychologist, we have a physiotherapist, we have psychiatrist, physio, and chronic pain team. All these services is to fulfill this purpose of making endometriosis patient journey less traumatic, less sort of debilitating, and eventually we can improve the quality of life. We can improve the fertility. We can do this. It's just not done simply with surgery. It's much more complex than that.
Yeah, so you see, ladies, a clinic that thinks of everything that you could possibly need and go through, which is a very rare find. So thank you for putting all of that together. Endometriosis surgeries without biopsies. So I've come across many women who've shared, I had my surgery. I was told I did or I didn't have endometriosis, despite imaging indicating that I do or don't. And then there's no proof. So, what are your thoughts on these surgeries that take place where biopsies aren't done?
Well, so the rule of surgery, if you remove something, then you don't throw it away into the bin, you send it to the lab.
Mhm.
Okay, so with rare exemption, of course, right? But if we do endometriosis surgery, if we remove a lesion of endometriosis, we have to send it to the lab. We have to send like a tissue which can be analyzed, right? So MRI, ultrasound, CT scan can suggest a few things, but the roles of these imaging modalities are accessory, right? The only diagnosis is when you have a tissue diagnosis, and that's a biopsy. So, what can happen if someone has endometriosis surgery and they see endometriosis and then they take, diathermy forceps and do ablation, then the histology is not sent because ablation means we're not removing anything, we're just burning it. And that's histology is not there. So therefore, the tissue diagnosis is not achieved. And that's why, again, ablation shouldn't be done. So if we do excision, then you cannot remove endometriotic nodule and not send it to pathology because that's what you have to do. And not only to rule out cancer, although cancer is quite rare with endometriosis lesions, but also to have a confirmation of your diagnosis. And sometimes, especially outside pelvis on the diaphragm, sometimes you have a spot of something which doesn't look like normal lining. You take a biopsy of it, it comes back either with endometriosis or it comes back as negative. In this case, you again reach the diagnosis, so that what you thought what would be an endometriotic lesion is actually just a bit of scar tissue. God knows where got that from, But, it's important to know, is it endo, is it cancer, or is it something else?
Yeah, so to confirm, with a ablation, there's no pathway with that type of surgery because of the lasering burning to actually take a biopsy, would it?
Absolutely correct,
Oh,
yes.
wow. Okay, that's a bit worrying. This is a big one because I see it all the time in the comments shared with me, but I would like to ask you, what are your thoughts on surgeries being performed without prior imaging being done?
Yeah, very wrong thing to do. You,
Mm.
you cannot just do a surgery without at least some understanding what you're going to find, right? And I tell you, the concept of diagnostic laparoscopy uh, was for many years the gold standard in diagnosis of endometriosis. But what it means, if you have a symptomatic patient, you do diagnostic laparoscopy. In diagnostic laparoscopy, if you find something like a little bit of endometriosis, mild to moderate stage of endometriosis, then you can potentially treat it with patient's agreement. If during diagnostic laparoscopy you find severe endometriosis, then you cannot do anything because A, you didn't know about this, and it's a finding during diagnostic laparoscopy which you cannot really act on. You don't want the patient to wake up and say, hi, we done your diagnostic laparoscopy and you don't have right ovary and part of the bowel was removed. So nobody will like that. And that's, it's not a nice practice to do it. And it's actually illegal as
Oh,
well. So, and the without imaging and ultrasound scan and normal sort of straightforward MRI scan may not be even enough for endometriosis mapping. If you suspect a patient who's got symptoms of endometriosis, especially if you suspect this like bowel endometriosis or urinary tract or chest endometriosis involved, you need to really be as close as possible to understand what's going on. And for that purpose, you need a specialist, tertiary unit level MRI scan with endometriosis protocol, because endometriosis MRI can detect deep infiltrating disease, can detect severe disease. It may not detect superficial disease, which is not a problem. If you have consent of the patient to treat superficial disease during your laparoscopy, that's absolutely fine. What MRI, in my case, MRI scan, some people do advanced ultrasound scan, which is also fine, but I think MRI is better. But if you don't have this advanced knowledge, advanced map of the disease prior to surgery, then your surgery is more likely to be abandoned if you find something more than just superficial disease, which you cannot easily excise. So that means the imaging is absolutely key in assessing, and it's not it's not only MRI pelvis, it's MRI abdomen and pelvis, sometimes diaphragm and chest, and that's very important. If your patient is symptomatic of upper sort of abdomen or chest endometriosis, then you have to image that. Without imaging, it's not a good practice to do that at all.
No. So, what would your suggestion be to, say, patients who either don't have medical insurance or can't afford to pay for a surgery privately? If they're being denied imaging on the NHS, would you suggest that they should at least, if they're able to, have an endo mapping MRI done privately ahead of any kind of surgery when it comes to endometriosis?
Well, it's hard for me to say everybody should go private
I know.
and everybody should drive a Lamborghini and travel business class. It's not possible. I guess, and this is the question to how the healthcare is actually organized in the country, and that's a big question. You can tell. For example, because I travel a lot as a robotic proctor in Europe and around the world, and I see in some countries like in Europe, it's not such a big problem, because if you if you are accredited endo center, you will have availability, you will have proper pathway for the patient, like imaging, MDT surgery, and when I start talking about how uh, variations on endometriosis care in the UK, people sometimes don't believe me, because I mean, is it possible? So yes, it is. But yeah, it's a question of us knowing how endometriosis service should work and how the healthcare is actually delivered in the country. And that's a big question. It's something that I can say, yeah, everybody should have this patient pathway if you're symptomatic of endometriosis, but is it going to be realistic within the NHS setting? It's, we need some serious improvements to the national health to be able to deliver that.
Yeah, it's a fair response. Yeah, it's very complicated. This this is quite a big topic in terms of I did a post on post-op sick leave because I'd seen on an online forum women saying that they'd only been signed off for like a week or two after major endometriosis surgery. So I did a post on TikTok referencing the NHS's own website, where it states that with laparoscopy, if you've had treatment or surgery, as they call it, as opposed to just a diagnosis, it can take 6 to 8 weeks to fully recover. Yet in the comments, the vast majority of UK-based patients shared that they were only signed off for 2 weeks, including those who had explicitly stated that we have physical jobs. And the majority would go back to work in pain and worse, many suffering complications. And because of the gaslighting around that all, they start to doubt themselves and be hard on themselves, because surely I should be okay by now. Surely I should have fully recovered by 2 weeks. And I feel that there is this misconception when laparoscopy surgery is labeled as minimally invasive, because yes, I'm presuming that's reference to the incision sites, which of course is a major factor. But what goes on with excision treatments, especially in stage 3, stage 4 cases, isn't minimal, it's pretty major. So, asking you, you as a specialist who's treated women with endometriosis, what do you typically advise? How long do you typically want to sign your patients off work for after such surgery?
Yeah, it's a good question. And basically, again, it's something to do with how the healthcare is organized, and yeah, the endometriosis care should be really, really individualized, right? Because sometimes you do a quick laparoscopy for some stage 1, stage 2 endometriosis, and patient go into a major pain episode after surgery. Why? It's not because you did something wrong. It's not because your surgery was a wrong type of surgery. It's because patients with chronic pelvic pain and neuropathic pain component can uh, do a flare-up of pain even after the successful surgery is undertaken. And that's something that you really can, foresee. So we never we never tend to give less than 4 weeks off work for any surgery that we do for endometriosis. And the way it works, we initially ask them to uh, secure 4 weeks sick leave, and then within 3 to 4 weeks after surgery, we see the patient in the clinic and discuss how's the pain control, how's your energy levels, can you physically go back to work. Most of people will say, yes, I've recovered, I want to go back to work because I'm a responsible professional, I want to and we can do the phased return to work. Sometimes you can work from home a little bit, or you can do some reduced hours if you still need to take strong painkillers, if you're still struggling with your bowel function or bladder function after surgery. Then working from home sometimes is a good thing. Sometimes phased return to work is a good thing as well, to like reduce hours or something like this. Yeah, if someone has like a major endometriosis surgery, we normally give 6 weeks. Again, in 4 weeks time, we always have a checkup in the clinic and see what needs to be addressed, and that's very individual. Some people, I had a patient recently who actually was trying to self-discharge herself from ITU following bowel resection because she wanted to go to work next day. I said, okay, well, you can. But
Wow.
yeah, some people recover like in an incredible way, and most people will need some rest, because if you take opium-based medications, then you cannot really do some work effectively. You need to rest, you need to sleep, you need to have these frequent meals rather than one big meal. So it's all part of the recovery, but and it should be individualized. Again, it's question of how the healthcare is actually organized and what's the pathway in this case. And even in a public sector, you can make your point when you're talking to a surgeon, to your endometriosis specialist. Make a point. Well, maybe with my chronic pain, if I have a flare, maybe I need some more time, and that's something that can be discussed. In the end, doctors are about caring for their patients, so I'm sure that will meet some understanding and sympathy.
Not always, from what I've understood. So, I don't know all of the legalities in this area, but technically speaking, as a UK practitioner, physician, if you were to sign me off for, as you did, for 6 weeks, my employer would have to accept that.
Well, I guess so. It's based on the advice of the medical officer. And most of the time, so I can't remember in my career where the recommended sort of sickness absence was challenged by the employer. Obviously, we're trying to be very reasonable. We're trying to be like very personalized,
Yes.
And if we need extension of the sick leave, we need to justify why. We need to see the patient again and write a medical report explaining why this patient needs a couple more weeks. Or sometimes after a major surgery, we say patient can actually go to work sooner because she is recovered and she feels able to do the work that she, and especially in the business world, people would like to go sooner if they can,
Yes.
because it's, the high profile job or something like this.
Yes, but that's good to know that, as you've explained with endometriosis, it's not just surgical pain. There can be, um, with the sensitization of the nervous system, it can be prolonged. There can be flares. So you're saying that, in your case at least, you're happy to revisit the patient's status, and if need be, and it's medically wise, you will offer an extension. Yeah.
Yeah.
Okay. Right. See. Okay, so next topic. This came up a few times, endometriosis and the kidneys. So in endo, we know we have such a thing as silent kidney loss. And there have been women that have shared that they have chronic kidney disease and endometriosis. And because of this lack of collaboration within MDTs in hospitals, they've kind of been treated as separate, or they're not looked at together at all. And the care is quite limited in this sense. So I guess questions to you, as an endometriosis specialist, are: how does silent kidney loss happen? And despite it being called silent, are there any symptoms, or I guess biomarkers, that a patient should pay attention to?
Okay, well, this is a very, very good question. And yeah, silent kidney loss means it's not really silent, because
Mm.
typically the patient will have lots of pelvic symptoms. So the kidney loss doesn't happen very often because endometriosis like consumes the kidney tissue or anything like this. The kidney loss happens when the ureter, the little pipe which goes from the kidney to the bladder, draining the urine from kidney to the bladder,
Yes.
gets gradually obstructed. And
Ah,
if it gets gradually obstructed, the kidney becomes more and more dilated. And if you compare this with sudden situation, for example, someone passes the kidney stone, which obstructs the ureter, that's like a super severe pain. This is the pain which most people describe as like worst pain in their lives. And that's because it's a sudden blockage of drain from kidney to the bladder. And that's
okay.
a kidney stone pain. When you have endo, the ureter is being narrowed year by year by year by year by year, and that becomes the kidney sort of trying to adapt to this, blockage of drainage, which is gradual, and suddenly and finally, kidney becomes more and more distended because kidney cannot cope with this, and can basically lose its whole tissue and function and become silently dead. So that's what endometriosis related kidney loss is. So, but most of the time, these symptoms are happening, or lack of symptoms are happening, with strong pelvic pain, menstrual pain, and other endometriosis symptoms, right? And if you don't investigate the typical endo symptoms like menstrual pain, pain with micturition, pain with bowel function, bowel motion, or you try and investigate it, but you're being ignored and not scanned, because a simple MRI scan will show you that the ureter is dilated, that
Ah,
the ureter is compressed. But if nothing is done and you have severe nodular infiltrating endometriosis near your ureters, that can result in a silent. Well, it's not silent. It's uh, no symptoms from the kidney, because kidney sort of is deteriorating slowly without major pain. Whether the sudden obstruction of kidney outflow is very, very painful.
gosh. So when you say the narrowing of the ureters can be spotted in imaging, is that pelvic MRI or it has to be abdominal MRI too?
Yeah, I mean, yeah, pelvic MRI. If the final part of the ureter, the distal part of the ureter, is being obstructed, then the ureter will become distended above the obstruction, right? So that pelvic MRI can find. If you look at the kidney, then you need to see kidney with abdominal MRI, because pelvic MRI, if it's confined to the pelvis, is not going to spot it. Yeah, and that's why pelvic alone MRI is not really recommended in endometriosis, because you need to see the whole abdomen. The whole abdomen needs to be visualized.
Yes, which in my experience and many women's experience is rarely done with the NHS.
Part of the problem is traditional understanding the gynecologist is someone who works in the pelvis, right? So, but endometriosis
Yes.
is outside pelvis in a lot of times.
And in your, I guess, your personal professional surgical experience, have you come across many cases of endometriosis of the ureters or kidneys?
Yes, endometriosis of the ureters are very common.
Oh,
Well, in our center, yeah, because we're sort of concentrating these cases to us. But yes, I mean, we're doing maybe 5-6 reimplantations of the ureter for this very problem a year. But unfortunately, we also had to do some removals of the kidneys for that very problem as well.
oh my gosh. Do you regularly catch it early enough before the kidney damage is done?
Yes, typically, yes. So if we see, if we have a symptomatic patient and we do endometriosis mapping with MRI, if we see dilated ureter, then it's a red flag for us to investigate the kidney. So we do another scan to assess the kidney function. Most of the time, we manage to identify the problem before kidney function starts to drop. But like I said, several times, not in 1 year, but several times where the kidney function is like less than 12%, you can't do anything with that kidney.
Wow. Okay. So in that case, when you just your reference to kidney function, um, if you have suspicions from imaging or symptoms about the kidney being affected by endometriosis, do you run any blood tests that looking at kidney function?
Yes, so we do the blood test just to do the electrolyte studies.
Right.
And that still can be normal, but because the other kidney can compensate, right?
Oh,
But what is needed to differentiate which kidney is working to which percentage is, the MAG3 scan, which is, a much more sophisticated scan which can separate right kidney is doing like 51%, left kidney is doing 49%. And that's a specialist scan which we do for these type of problems.
um, it's good to know that there are investigative methods because the women who obviously have it on their ureters and they're on 2-year wait lists for surgeries, or they've got chronic kidney disease and there's no idea if endometriosis is involved, at least they're aware that there are ways to investigate if they are able to go elsewhere.
Yeah, we become very excited if we see a dilated ureter on the imaging. That is
Yeah.
a red flag.
Uh, that you need to act.
Yeah.
Yeah. Yeah. Okay, thank you for that. That's going to be really helpful because you don't often hear people talk about kidney loss with endometriosis. Moving on to another big topic, which is fertility and pregnancy. So, many women find out they have endometriosis because they have trouble getting pregnant. Otherwise, they've been asymptomatic or haven't been aware of endometriosis to consider any overlap with symptoms. There are women who are considering egg freezing, women who are worried that endometriosis is making them infertile because we've come to understand that it's actually maybe the number one cause of infertility in women. There's that propagated view within healthcare, historically and even to date, that pregnancy will sort out your endometriosis, whereas actually there are women who have shared their stories online where pregnancy was uncomfortable, it was painful because of their endometriosis. So, starting going to go through a few questions that commonly come up. The biggest one being, which I mainly see from younger women, is can women with stage 4 endo and or adenomyosis get pregnant?
Yes, they can.
Okay.
And so it's complicated, right?
Mm.
So we see people who get pregnant with most horrible stage 4 deep infiltrating disease. We see people struggling to get pregnant with a very light peritoneal disease. So we don't know exactly how it works, but we've seen both extremes of the issue, right? You know,
Yeah.
and so if you think about it, so endometriosis can be responsible for up to 50% of infertility cases. And also, the condition is so complex that there is no real answer to what is going on. So we know that endometriosis can affect fertility on many levels. For example, it can affect the patency of fallopian tubes. So you can seal the fallopian tubes, create a situation called hydrosalpinx or hematosalpinx, or just block the fallopian tube at the very, with very origin. And that will stop your natural conception because the tubes are essential for that. Also, endometriosis can affect ovaries and diminish the ovarian reserve, that diminish the amount of eggs that you have in the ovaries. And women do not produce new eggs, though they're born with a certain amount of eggs, and you don't make new eggs during your life. So, an endometriosis can destroy the ovary by forming these endometriotic cysts or endometriomas, and those eggs tissue become consumed by endometriosis, and that can diminish the reserve. Also, it can, if you have a peritoneal endometriosis, it can create a particular hostile environment in the pelvis by releasing these inflammation chemicals, and those can make implantation and the fertility process, which is very, very complex, even more complex and impossible. So endometriosis can affect fertility on many levels, but there is no sort of universal route for. It doesn't mean that if you have endometriosis and you want to get pregnant, not necessarily you want endometriosis treated before the pregnancy. Because again, it's very personalized. For example, knowing that endometriosis is not cancerous, for someone who has endometriosis diagnosed, and then they said, can we try for a baby first? Yes, you can. Endometriosis typically does not progress very fast during pregnancy because of the progesterone dominance. So you don't have periods when you're pregnant. Therefore, endometriosis, strictly speaking, does not respond to the menstrual cycle sort of hormonal fluctuations.
Yeah.
But it doesn't go away in pregnancy, unfortunately. Yeah, after pregnancy is finished and the cycle is restored, the whole thing wakes up. And you also have to be very careful when you're dealing with ovarian endometriotic cysts. So an endometriotic cyst on the ovary can reduce the reserve of the ovary by consuming the healthy eggs, right?
Yeah.
Surgery to remove endometriosis from the ovary can also damage the ovarian reserve because you remove endometriosis, but you inevitably you remove some healthy ovarian tissue, right? So it's a balance. And we don't know, well, we sort of have an idea what's the best. Is it best to just drain endometriosis from the ovary, or is it better to excise endometriosis,
Yes.
accepting there is no sort of way of treating ovarian endometriosis without potentially affecting the ovarian reserve, if you follow, yeah?
Yes.
But overall, is the consensus is better to excise endometriosis, but you have to do it in a very delicate way. And that's where robotic surgery is really best of the best, because with robotics, you can do a very, very delicate excision of endometriosis from the ovary with preserving as much healthy ovarian tissue as you can. So, and that's probably the answer. Sometimes we drain the ovarian endometriosis. If you drain them and leave them, they will refill within a month, and most of them will. Sometimes we drain the ovarian endometriosis and then put patient on a very strong hormonal suppression to stop the menstrual cycle. Again, and that's, doesn't get rid of endometriosis, but it does probably prevent the refill of the cyst. And very important, and I think everybody should do that, when you have ovarian endo, and considering surgery, I think it's best to know what the ovarian reserve is like. Because if ovarian reserve is normal or high, then perhaps if you do the delicate and very sort of meticulous excision of endometriosis from the ovaries, you're not going to damage critically the ovarian reserve.
Yeah.
But again, it depends how the surgery goes. But also, if your ovarian reserve is diminished before surgery, then probably you should think about what else can we do to try and minimize the catastrophic loss of the ovarian reserve. And in this case, sometimes egg freezing comes handy, because if the ovarian reserve is reduced for the patient's age, we normally send these patients to people for reproductive medicine consultation, to fertility consultant, and to discuss what can be done to secure some eggs maybe before surgery, and then proceed with endometriosis treatment. So again, the whole thing with this endo and fertility is personalized. You cannot just apply the same policy to everyone. It really depends on the circumstances of the severity of the disease, of the personal fertility, aspirations, etc.
And by women checking their egg reserve, that's with the AMH test, anti-Mullerian hormone test.
Yes.
Okay. And is that something you would advise, regardless of age? Will you recommend that patients test their AMH, so there isn't this belief that because a patient is 22, there's no need to bother testing the AMH? Is it something that you will recommend, because it can vary in each individual?
Yeah, so I think information is key. If there is even slight desire to have a pregnancy for this patient, and if she's got severe endometriosis, then information what is the state of the ovaries is really important. You cannot assume. We've seen 22-year-old with literally zero ovarian reserve.
Wow.
Okay. And we've seen 54-year-old with like high reserve. So it's really, you cannot assume things like this. But information is key. The more information you get before endometriosis treatment, endometriosis surgery, the better. And as part of our consultations, we always ask about fertility. And if fertility is something which is really important for this particular patient, then we offer AMH testing for this patient.
Yeah.
We offer fertility consultation. We offer, a more detailed chat with reproductive medicine consultant about what options we have. And that's, I think, very important.
Yes. So you prioritize it from the beginning. You prioritize addressing it from the beginning.
Yeah, so we understand that women's health is the dragon of 100 heads, and we have to address each head at the same time.
Yes. It's a good way of putting it. Okay, because you answered quite a few other questions. I'll just see if there's anything. I guess just revisiting egg freezing and IVF. I know you've more or less said it's very much case by case, but typically, or like what's ended up transpiring in your clinic, is follicle extraction typically advised before or after excision surgery?
It depends. It depends on, first of all, we need to know what's the AMH like before we do anything at all. Because if we do surgery with low AMH, then we lower it further down, and the egg collection may not be even possible if we diminish the ovarian reserve. So information about AMH is key before you do anything invasive, right? So, and then once we have these assessment of the ovarian reserve, then we discuss with the patient. Some people say, yes, the AMH is a bit borderline, so I really, really want to get pregnant, and I don't really want to lose that opportunity to get pregnant. In this case, it's better to have a chat with fertility clinic, and because they wouldn't say, no, you need egg collection, egg freezing. They'll say, this is an option. And this option means we can try and stimulate your ovary. We can try and collect the eggs. We can store your eggs, uh, you know, uh, for whatever amount of years that you need them. And we can transfer them into the embryo and do IVF if we need to. It's all about what patient wants. It's all about what we can offer. But the key thing is knowing as much as possible about the patient before doing surgery.
Yes. Yes, and so typically speaking, just so I'm clear, the main test biomarker for fertility is AMH. Of course, there's other factors like if women are cycling regularly, and then of course you've mentioned the extent of the endometriosis and inflammatory chemicals that could be, despite having good AMH, that could be opposing pregnancy.
Yes. So AMH is only one sort of, one component of fertility. So you have to consider the whole picture.
Yep. Okay. Now, moving on to menopause. So, menopausal women, from what I've seen online, are dismissed and refuse treatment, even if they're just approaching menopause, so they're perimenopausal, because they've been told by their healthcare provider that endometriosis will go once you hit menopause. Menopause is the end of endometriosis. I've also seen women comment that in perimenopause is when they actually experience their first ever endo flares, that they've potentially been asymptomatic, and then when perimenopause occurs and the hormones are out of balance, they start to experience these symptoms and find out that they have endometriosis. Then there's the element of getting HRT right. So, of course, there's been a lot of talk about HRT recently, that it has been villainized historically, but actually the importance of estrogen when it comes to women's health and longevity. Of course, with endometriosis, estrogen has more or less been demonized in our eyes. We've been told things like you're estrogen dominant, you have too much estrogen, it's making your endometriosis worse, your endometriosis is producing its own estrogen. So we associate negatively with estrogen. Quite a lot of information there, but just to understand from yourself as an endometriosis specialist, does menopause resolve endometriosis?
No, it doesn't.
No.
So menopause is when the secretion of estrogen diminishes, right?
No.
So by the ovaries. So
Yes.
and as endometriosis is estrogen dependent disease, logically speaking, that could be stopping endometriosis progression. But there are some issues here. So first of all, if you become menopausal and you go on HRT, HRT will contain estrogen. That means the endometriosis will wake up and will be feeling very comfortably, progressing, causing symptoms, growing, infiltrating, etc. Even if you use combined HRT, it doesn't really stop it, right? So secondly, if you have endometriosis and you're not an HRT, then there are some research to suggest that endometriosis can produce its own estrogen as part of its sort of pathologic development, and that again can be a problem. So basically, in menopause, it's like before the menopause, you just need to see if you have lots of symptoms, if you have lots of pain, if you have if you're known to have endometriosis and you're going through menopause and started HRT, that if your symptoms still debilitating and active and regular, then you have to do something about it. So menopause doesn't cure endometriosis. Certainly it doesn't disappear, it doesn't dissolve, it doesn't really go anywhere. It can be inactive
Ah,
and stop causing symptoms, but also it can be active and progressive.
ah. So best case scenario is that it becomes inactive.
Yes, and most people with menopause without HRT will find the endometriosis got better. Doesn't mean it's actually gone anywhere, but they feel because the period has stopped, the period pain has reduced or gone, and that's how. But it doesn't go away. Unfortunately, it doesn't. You can still have it reactivated if you start HRT.
So in that case, women who are post-menopause and symptomatic or approaching menopause, they shouldn't be dismissed. They are worthy of treatment because technically speaking, endometriosis may remain active in those
Correct.
years.
Yeah. Nobody should be dismissed if they have pain.
Yeah. Yeah. And I'm curious, how often do you come across postmenopausal patients?
Well, quite a few. Yeah, yeah,
Yeah.
yeah, 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 quite a
Wonderful.
few. So it's not exotic to see a menopausal patient in endo clinic anymore. I think if they remain having pelvic pain, they want to know what's happening, and
Yeah.
especially after the menopause, the awareness of the cancer, ovarian cancer, etc., is sort of is on people's minds as well. So they want to know, I'm like 60 and I have this a lot of pain. Is that cancer? And then when you start talking to them, say, yeah, I actually had endometriosis, which got better, and then I started HRT, and it's back to its full pain again. So
Ah, gosh. And do those women, out of curiosity, tend to opt for surgical intervention?
yeah, we discussed the surgical options with them. We operate on them. Yes, definitely,
Okay,
they get
good,
better afterwards.
good. God, that's a relief to know that they're also um, given access to treatment and not told it will get better, don't worry. With the fact that you touched upon ovarian cancer, so the comparisons between endometriosis and cancer. Obviously, it's not cancer, but it's often referred to as a benign cancer. The way it behaves and infiltrates the anatomy causes inflammation and organ dysfunction, and even in some cases, as we've discussed, organ loss. And the fact that women who have endometriosis, I believe it's stage 3, stage 4, and in particular endometriomas, have a slightly higher risk of ovarian cancer. So, a few questions to you would be, what are your thoughts on the comparison between endometriosis and cancer? Do you see that crossover in your patients where they have both? And do you think that, given that we know that women with endo have a slightly higher risk when it comes to ovarian cancer, which is also one of those silent cancers in terms of women tend to find out too late about it, do you think that there should be better screening protocols in place for women who have endometriosis?
Mm. Well, yeah, endometriosis is not cancer. We don't think it's precancerous disease, strictly speaking,
Yeah.
although it shares some cancer-like behaviors, like invasion, yeah, inflammation, but malignant transformation of endometriosis is uncommon. I've seen a few, but that's not really a common thing to find. So we don't treat as endo as precancerous condition. And that raises another important issue, because if the definition of screening is detecting, let's say, cancer before it became cancer. And if you want example of this is cervical screening. So we can detect cervical abnormal cells and HPV virus before you get cervical cancer, and that's screening. With ovarian cancer, there is no pre-malignant stage, so we cannot really screen people
Um,
for ovarian cancer because there is no understandable pre-malignant stage, okay? And there was certain attempts made to try and do the ovarian cancer screening with like the CA125 test and with the scan, but those are not very efficient in terms of if you want to do the mass screen, like national program of screening, it doesn't really still, it doesn't seem to be feasible. So we believe that especially ovarian endometriotic cysts make the chance of cancer maybe increase like 2-3-fold. Okay. And you're quite right. The ovarian cancer is a very late presentation disease. And the symptoms are not specific until you find this is stage 3 or stage 4. So my sort of practice and my belief, if you like, if you're known to have ovarian endometriotic cysts, nobody should go to menopause with those cysts and sort of forget about them. So you either need surgery or you need a very delicate monitoring of these ovarian endometriomas. Again, this is a tricky thing because, like I said, because of the screening limitations, but endometriosis in menopause, again, raises a sort of awareness of the ovarian cancer later in life.
Yes. Well, that's very helpful to know that women should be aware if they are approaching menopause and they have endometriomas that they shouldn't ignore them.
Yes.
Yeah. Oh, I know you have to go, but thank you so much for doing part 2 with me. I really appreciate it.
My pleasure, Lina.
Mhm.
Okay.
Thank you
All
so
right.
much. Bye, Mr. Tsepov.
Take care, Lina.
You too. Bye bye.
Bye.